This is my first talk as a consultant, so I am a bit tensed. But I am very privileged to give this talk in a session chaired by Dr. Sir. Sir, you are my teacher's teacher, so you are Adi Guru in the field of endocrinology. I feel relaxed that he will be shielding me for question answer session. So coming to the thyroid physiology with an increase in renal iodine excretion, thyroxine binding proteins, thyroid hormone production, and also there are added to these there are thyroid stimulatory effects of HCG. All these factors influence thyroid function tests in pregnant women. Furthermore, the reference ranges for the most widely applied tests, that is TSH, T4, free T4, vary significantly in different populations. So all these make interpretation of thyroid function tests in pregnancy a very difficult thing. So you can see here that as the maternal HCG increases, the trimester associated with an increase in free T4. There is increased GFR in pregnancy responsible for increased iodide clearance that in turn causes goiter in iodine deficiency areas. Also there is increased demand for thyroid hormones. The placenta has type 3 deiodinase which inactivates thyroid hormones. So there is increased demand for thyroid hormone production. That is the reason why in normal pregnant women, 15% of them we see goiter. So I would like to discuss in the form of case scenarios, and this is especially for the obstetricians. I want them to be really active and take part in this. So the first case, 25-year-old G2P1L1 at 10 weeks of gestation as on ultrasonography. On routine evaluation was found to have a T3 of 170, T4 12 and TSH 0.01. There is no past history of thyroid disease, no signs or symptoms of hyperthyroidism. I would like to ask the obstetricians present over here, what would be their next step of action? Is it to start her on methimazole, start her on propylthiouracil, repeat the test after 4 weeks, or refer the patient to an endocrinologist? If you ask me, my favorite option would be option D. And remember, I work in Dr.Naga branch. Jokes apart, the one important thing that we have to ask in the history is hyperemesis gravidarum. Because gestational transient thyrotoxicosis is the most common cause of thyrotoxicosis that we see, especially in the early part of pregnancy. It is seen in 1 to 3% of pregnant women and often associated with hyperemesis gravidarum. So there is excess secretion of HCG from placenta, and HCG cross-reacts with TSH receptors present on thyroid gland, which results in increased thyroid hormone production. And these thyroid hormones in excess will suppress the TSH production from maternal pituitary gland. So overall you have a picture of elevated thyroid hormones and a suppressed TSH. And a diagnosis of hyperthyroidism can be made in this. Ultrasound, because ultrasound can diagnose a molar pregnancy. So there is snowstorm appearance, hyperechoic mass with multiple cystic spaces within it. Gestational trophoblastic disease comprises complete and partial hydatidiform moles, choriocarcinoma, invasive mole and placental site trophoblastic tumor. So in India, the incidence rate is around 1 in every 400 pregnancies, and everything depends on beta HCG levels. Like in cases where beta HCG levels is more than 2 lakhs, almost 67% chances of having a TSH suppression, whereas if it is more than 4 lakhs, 100% of cases have a suppressed TSH. And also, depending on the severity of trophoblastic disease, the clinical spectrum can vary from completely asymptomatic to a severely thyrotoxic patient. And what is the treatment? Suction evacuation. But if you feel that the patient is severely toxic and needs stabilization, you can try a short course of beta blockers. But definitive therapy is suction evacuation, both for the treatment of molar pregnancy as well as for the control of thyrotoxicosis. Then the third case, a 24-year G2P1L1 with 14 weeks of gestation with a T3 of 424, T4 22, TSH 0.01 and a 6-month history of weight loss, anxiety, palpitations and tremors. And on examination there is tachycardia, fine tremors, lid retraction, grade 3 diffuse soft goiter. So I think the diagnosis is clear cut because the history is of 6-month duration and there is a diffuse soft goiter, and even the T3, T4 are quite elevated with a T3, T4 ratio more than 20:1, all pointing to Graves' disease. And Graves' disease is the commonest cause of hyperthyroidism in pregnancy, seen in about 0.1 to 0.4% of population, and an Indian study reported about 0.6. There is fetal goiter formation. In fact, this is the earliest sign on ultrasonography that a fetus is affected with thyrotoxicosis. Then there is hyperthyroidism seen in 1 to 5% of cases, and it all depends on the levels of TRAPS. IUGR, failure to thrive, fetal or neonatal hypothyroidism, and also central hypothyroidism can be seen. So the management of such cases should start from the preconceptional period. That is, when a patient is planning a pregnancy, you have to give her all the 3 options available: radioiodine ablative therapy, thyroid surgery, and medical therapy. Each of vaginal atresia and so on, seen in about 3 to 4% of cases. So ATI recommends shifting such patients to PTU. And what is the conversion like? Suppose a patient is on 5 mg per day of methimazole, you need to give her 100 mg per day of PTU. Because PTU has shorter half-life, we give it in 2 or 3 divided doses. So you can give her 50 mg BD of PTU. So after 16 weeks, though ATA says no recommendation regarding switching of antithyroid drugs can be made at this time, in clinical practice, we shift the patient back to methimazole after 16 weeks of gestation, because in 0.1% of cases, propylthiouracil is associated with fulminant hepatic failure requiring liver transplantation. Then how to monitor such patients? So free T4 or total T4 and TSH are done every 4 weekly. Now, if there is, if the lab has facilities of doing equilibrium dialysis and HPLC and tandem mass spectrometry, and if the trimester-specific reference ranges are available, then you can get free T4 done. Otherwise, total T4 can be done. And generally, in the 2nd and 3rd trimester, the upper limit of total T4 in pregnancy would be 1.5 times that of the non-pregnancy reference range. So you can do free T4 or total T4 and TSH every 4 weeks. And see that they are maintained at the upper limit or even just above the upper limit of normal. Never try to overcorrect hyperthyroidism in pregnancy, because if you are seeing that TSH is within normal range or free T4 is within normal range in the mid half of the range, that means you are overcorrecting hyperthyroidism and you are increasing the likelihood of fetal or neonatal hypothyroidism as well as goiter formation. And we don't want that, so always undercorrect hyperthyroidism. Keep the T4 or free T4 in the upper limit or just above the reference range. And to the extent possible, administer the least effective dose of methimazole given. So they found that antibody positive but treated patients behaved like antibody negative patients, whereas antibody positive patients who were not treated had a progressive elevation in TSH and a fall in free T4 as the pregnancy progressed. Not only that, there was increase in the incidence of miscarriage. This was so when antibody positive women had a TSH more than 2.5. And antibody negative women did not have such effects until their TSH was below. No family history of thyroid disease. On examination, there is grade 2 goiter. So this is a case of overt hypothyroidism in pregnancy. Overt hypothyroidism is when TSH is more than 10 or TSH is between upper reference range and 10 but associated with a low pre-T4. So complications being pregnancy loss, preeclampsia, placental abruption, preterm delivery, lactation problems, postpartum depression, increased perinatal mortality in pregnancy. So here also the management should start in the preconception period. So you have to explain to the patient the risk of hypothyroidism in pregnancy. You have to adjust her L-thyroxine dose such that it is maintained below 2.5 at the time of even before she actually conceives. And also 50 to 82 additional tablets weekly for the patient's current daily dosage. That is, if the patient is on 100 mics per day and she conceives, you can ask her to take 125 micrograms per day, or you can ask her to continue with 100 micrograms per day, but give 2 tablets. Say suppose Saturday and Sunday, ask her to take 2 tablets of 100 mics L-thyroxine. So monitoring of antibody positive females, or who have undergone a hemithyroidectomy, or who have undergone radioiodine surgery, because they have high risk of developing hypothyroidism as the pregnancy progresses. And also, once the patient is maintaining euthyroid status by mid-gestation, you can repeat TSH testing again at 30 weeks of gestation. So ATI recommends targeting all patients with a TSH more than 2.5 antibodies have to be done. Suppose TSH is less than 0.1, you investigate in lines of thyrotoxicosis. If it is 0.1 to 2.5, everybody is happy, we need not do anything, patient is maintaining perfectly normal thyroid function. And if it is 2.5 to 10, there lies the problem. So you have to get antibody titers done. And if antibodies are positive, generally we treat all antibody positive patients. If
what is the future implications of it? So we always do, that is my habit out of that. And another thing is, there are several, I think, American College and Evolution, so many other guidelines are there when actually to start the thyroid, or when to tell the patients to go to the endocrinologist. Now you have said that it is 2.5. So are we all actually following in the entire Hyderabad 2.5 as a cutoff level? To refer to the,
no,
to start it.
Actually 2.5 is when you get antibodies checked. 2.5 is, previous guidelines were like all more than 2.5, all patients start at ATA guidelines around 2011, but now it was changed because they found that it is not 2.5. They thought that
you say that all the obstetricians to run a pre-conception clinic. I think the time has come that we must insist on a pre-conception clinic. So not only the thyroid but the diabetes and all that can be screened and a proper screening to be done. And proper advice is given prior to conception. Number two is every family must be told about the problem of iodine prophylaxis. You know, the iodine is the only one which is very important in pregnancy. And despite decades of iodination in India, most of the people are iodine deficient. That is mainly because they don't know how to use the iodized salt.
Iodine deficiency, we absolutely neglected. See, in mid-90s when 275 districts in the non-iodine belt area, when the surveys were done by the central institutes and the government of India, 235 districts were found to be iodine deficient. Even in the erstwhile Andhra Pradesh, after 7 districts, 6 were found to be iodine deficient. Or really sometimes it looks really, what is more important is what is the method they are doing, how they are collecting, when they are doing, what lab, are they maintaining standardization, precision of testing of these labs. These things are important along with your clinical findings and your T4 levels. I think these things are important. And third is, because most of the well-conducted randomized clinical trials have not really shown the good outcomes with the replacement of therapy. So, it's still a controversial issue. So, and the other thing which I like to point out is, in the pregnancy, sometimes, management of nodules is also important. You come across. You would have put one more case of nodule, it would have been good. Right? Yeah, good presentation. Thank you.
The latest guidelines is 4 units of TSH, not 2.5. Now it is increased to 4. So you start treating only if it is more than 4 and above. So is it 2.5 or 4?
If it is more than, if antibodies are negative, then you only consider treatment if it is more than 4.
Literature in return. A sincere thanks for your valuable time.
You got to use